Welcome to the lecture on traumatic brain injury, or TBI. My name is EmilyReid, and I will be your guest lecturer. I am a graduate student in Dr. Spires' lab, and I have a particular interest in traumatic brain injury. For my master's thesis, I have chosen to examine gender differences in sports-related concussions, which is a specific type of traumatic brain injury. We will cover sports-related concussions briefly in this lecture, but if you would like to learn more, please note the resources slide at the end of this lecture. Before we begin, we should differentiate how traumatic brain injury is different from other brain injuries. TBI is an acquired injury caused by an external physical force. This is different from a stroke or a tumor, which are caused by neurological disorders or diseases. Traumatic brain injury is a significant public health challenge. Approximately 2% of the U.S. population currently live with disabilities from TBI. The CDC estimates that 1.5 to 2 million people suffer a traumatic brain injury every year in the United States. A small proportion of those, approximately 275,000, are hospitalized, whereas 1.4 million are treated and released. The CDC based their estimates on head injuries seen in emergency rooms, which means these numbers are likely to be an underestimate of incidence, since many people do not go to the emergency room for their injuries. Additionally, it is estimated that 1.6 to 3.8 million sports-related traumatic brain injuries occur each year, of which many are treated on the field and do not seek emergency room assistance. What are the ways someone can acquire a traumatic brain injury? Falling is the #1 cause of TBI and explains approximately 35% of those head injuries. Falling is a particular concern to people who are over 65 years of age. Motor vehicle accidents, striking or being struck by an object, and assaults are the other leading causes of TBI. Compared to other causes, motor vehicle accidents result in the highest number of fatalities, approximately 52,000 per year. An emerging area of concern in TBI research is veterans who have experienced blast-related head injuries. When explosive devices detonate, the force from the wavelengths of the blast wound a soldier by causing concussion-like symptoms. According to the Brain Trauma Foundation, exposures to blasts are a leading cause of TBI among active-duty military personnel in war zones. It is believed that between 10 to 20% of Iraq veterans, or 150,000 to 300,000 service members, have some level of TBI. 30% of soldiers admitted to Walter Reed Army Medical Center have been diagnosed as having had a TBI. Another emerging area in mild traumatic brain injury research is sports-related concussions. The research in this area has been driven in particular by the discovery of a new brain disease called chronic traumatic encephalopathy, or CTE. CTE is a progressive degenerative disease of the brain found in athletes and others with a history of repetitive concussions. CTE has been known to affect boxers since the 1920s. However, recent reports have shown CTE in retired professional football players and other athletes who have a history of repetitive brain trauma. This trauma triggers progressive degeneration of the brain tissue, including the buildup of an abnormal protein called tau. These changes in the brain can begin months, years, or even decades after the last brain trauma or end of active athletic involvement. The brain degeneration is associated with memory loss, confusion, impaired judgment, impulse control, aggression, depression, and eventually progressive dementia. These are all symptoms we will cover more in depth later in this lecture. To learn more about this disease, go to the researchers' website for the Center for the Study of Traumatic Chronic Encephalopathy at Boston University. Neuropsychologists are on the front lines of this issue with the implementation of computerized neurocognitive testing for athletes to assess their neuropsychological functioning after a concussion. The most widely used computerized testing system is called IMPACT. The computerized testing helps inform return-to-play decisions and therefore helps determine recovery time. The testing is already widely used among professional sports teams, Olympic teams, and is becoming more common for college and high school athletic teams. Did you know that Drexel University uses computerized neurocognitive testing? TBI is the leading cause of death and disability for children and adults under the age of 44. Those most vulnerable to TBI are children ages 0 to 4, older adolescents ages 15 to 19, and adults over 65 years of age. Across all age groups, men sustain at least twice as many head injuries as women. And male children, ages 0 to 4, have the highest rates of TBI-related emergency visits, hospitalizations, and deaths. Sustaining a brain injury can be life-changing for a patient, as well as for their family and friends. Financially, the lifelong care for a single person with a TBI is estimated between $600,000 and $1.9 million. These are likely underestimates of the actual cost, since these numbers do not reflect the lost earnings, costs to social services systems, and the value of time and foregone earnings of family members who care for patients with TBI. TBI also has a strong economic impact. In a 1998 NIH report, an estimated $9 to $10 billion were spent on new TBI cases each year. Are all traumatic brain injuries the same? The answer is no. We've already discussed the different ways someone can acquire a brain injury, but there is even variation in the type of brain damage done. A traumatic brain injury can result from an open or closed head injury. An open head injury is defined by having an object penetrate the skull and meninges, creating an open wound. On the other hand, a closed head injury is caused by rapid acceleration or deceleration of the brain without penetration of the skull. In an open or penetrating head injury, the skull and the covering of the brain or meninges are ruptured. These injuries occur when an object, such as a bullet, knife, or bone fragment, lodges or passes through the brain. Because the brain is exposed, infection is a concern. Penetrating head injuries may create more focal damage than in a closed head injury. Therefore, the pattern of behavioral deficits is dependent on the location of the injury. After effects of the initial injury, including swelling and bleeding, may cause more global, though usually time-limited, effects due to intracranial pressure or inflammatory response. The majority of head injuries are closed head injuries, or injuries where the skull is not penetrated. These injuries occur by either direct impact, such as a helmet-to-helmet hit, or whiplash, where there is no direct hit to the head. In both these cases, the brain undergoes a rapid acceleration, deceleration, or both. In this slide, we see that as the head and neck move, so does the brain inside the skull. As a result of the acceleration and deceleration, the injuries sustained are not just at the point of contact. In this slide, the person gets hit by a bat at the point of injury. However, there's also a secondary impact when the brain tears away from the skull in the opposite direction of the original impact. Contusions and/or hematomas may be seen at the location of impact, that is where the bat hit, which is also known as the coup. Contusions and hematomas may also be seen at the opposite side of the brain, or the contracoup. The coup and contracoup injuries are the direct result of the acceleration and deceleration the brain undergoes and can exist even in situations like whiplash, where there is no object hitting the head directly. Regardless of the location of impact, a pattern of diffuse injury is likely to occur, impacting the frontal lobes and temporal poles in particular. Because of the jagged surface of the skull plates that hold these lobes in place, when the brain moves, it rubs against these jagged surfaces, causing axonal damage. This diffuse damage to the brain in a closed head injury is referred to as diffuse axonal injury, or DAI. Specifically, the axons of neurons are stretched, compressed, twisted, and torn when this type of injury occurs. This shearing of the axon can result in cell death. However, neurons aren't the only structures damaged in DAI. The physical forces may shear, tear, and rupture blood vessels or the meninges as well. This diffuse axonal damage causes less axonal connections, resulting in less efficient neuronal transmission. It also results in atypical metabolic cascades. Most importantly, DAI causes widespread damage, which may change over time. The neuropsychological and behavioral consequences of TBI are related to injury characteristics and severity. Loss of consciousness and emergence into consciousness are two injury characteristics of great importance when determining severity of TBI and predicting outcome. Loss of consciousness and coma are directly associated with an injury to those areas of the brain, typically the lower brainstem and reticular activating system, that are involved in maintaining consciousness and arousal. For example, someone who sustains a mild traumatic brain injury can have 0 to brief periods of loss of consciousness, whereas a severe head injury can cause a loss of consciousness for weeks. Similarly, emergence into consciousness ranges from minutes to hours in mild traumatic brain injury, or MTBI, whereas for severe head injuries, it can range from weeks to months. Depending on the severity of the injury, the corresponding recovery of neuropsychological functioning can range from days to years. The recovery from coma is a process of emergence in which greater awareness of environmental stimuli occurs. Characteristic of traumatic brain injury is a loss of recall for the actual impact event. Since the injured person does not recall the event, he or she cannot usually give a reliable account of the length of loss of consciousness. This loss of memory around the event is called post-traumatic amnesia, or PTA. PTA is characterized by confusion and disorientation and typically includes both retrograde and anterograde amnesia. Retrograde amnesia refers to the inability to recall events preceding the injury. Conversely, anterograde amnesia is impairment in encoding new memories after the injury. Compared to length of loss of consciousness, post-traumatic amnesia is considered a better overall predictor of brain damage. Unlike what is presented in movies, comas actually fall along a continuum related to depth of responsiveness and are typically assessed at regular intervals after an injury using the Glasgow Coma Scale, or the GCS. The GCS assesses the best motor, the best verbal, and the best eye-opening responses at one point in time. Scores range from 3 to 15. At the best score of 15, a person can obey motor commands, is oriented, and their eyes are open. At the worst score of 3, the patient has flaccid motor responses, cannot respond verbally, and their eyes are closed. The GCS scores are used to help classify the severity of the injury. Medically, coma is defined as a score of 3 to 8, which typically corresponds to a severe brain injury. It should also be noted that greater mortality is typically associated with scores below 7. The difference in diagnosis between mild, moderate, and severe head injuries relates both to the GCS at the time of admission and the time it takes for the symptoms to resolve. For example, MTBI is characterized by a GCS score of 13 to 15, a fairly rapid resolution of loss of consciousness that is less than 30 minutes, and post-traumatic amnesia less than 24 hours. This means that the patient lost consciousness for less than 30 minutes, and their amnesia, both retrograde and anterograde, does not span more than a 24-hour period. Moderate level brain injuries are characterized by a GCS score of 9 to 12, loss of consciousness between 30 minutes and 24 hours, and PTA between 1 and 7 days. The most severe brain injuries require a loss of consciousness greater than 6 hours. The graph shows that the majority of head injuries, or 80%, are mild traumatic brain injuries, whereas the remaining 20% is divided relatively equally between moderate and severe head injuries. The remainder of this lecture discusses the neuropsychological consequences of TBI. However, as we know, behavior is related to particular brain regions, so let's revisit the most common sites of injury in a closed head injury. The most common brain regions that are injured during a closed head injury are the frontal and temporal lobes because that is where the brain rubs against the plates of the skull. The anatomical illustration on the left is depicting the intersection of the frontal lobe and temporal lobe with the bony plates of the skull. The picture on the right shows the contusions from 40 separate cases of TBI. As you can see, the locations of injury are consistently in the frontal and temporal lobes. Therefore, the behavioral deficits we expect to see should correlate to the neuropsychological processes that these regions are responsible for. The neuropsychological consequences of TBI may include deficits in the neuropsychological domains of attention, memory, language, executive functioning, and emotional problems. Keep in mind that these are not problems everyone will experience, but are generally the typical impairments seen across TBI patients. Regardless of injury severity, attentional deficits are common after TBI. Reports include a feeling of mental slowness, difficulty following conversations, losing their train of thought, and trouble with multitasking. The most universal consequence is a reduced ability to process information. Therefore, when tasks become more complex, reaction time becomes slower. As a result, a TBI sufferer may not appear cognitively impaired in simpler routine assessments, but the deficits may become more evident in the multi-component tasks of daily life. Think about when you are very, very tired. It is more difficult to think quickly and to successfully multitask as when you are refreshed. This is similar to what someone with a TBI experiences. In addition to attention difficulties, a deficit in memory is a hallmark feature of TBI. Memory impairment is one of the most frequent and long-lasting complaints for patients with TBI. As we discussed earlier, post-traumatic amnesia, or PTA, which often consists of deficits in retrograde and anterograde amnesia, is almost always seen after a TBI. Usually retrograde amnesia shrinks with recovery so that patients begin remembering more and more of the events leading up to the accident. While anterograde amnesia remains, it is difficult for a patient to encode new memories. However, a patient may demonstrate islands of memory, where vivid, detailed, autobiographical memories can be recalled for certain post-trauma events. As PTA resolves, a patient's state of confusion lifts and they regain their declarative memory. A complication for caregivers, including family and friends, is that patients tend to be less aware of their memory difficulties than those around them. A TBI patient may also experience language and communication difficulties. Speech can be less productive and efficient. Their speech may be more fragmented, or they may speak for a longer amount of time with less content. Additionally, language difficulties may include trouble naming objects and, to a lesser extent, comprehension of complex commands. Deficits in executive functioning influence functional, emotional, and social outcomes after TBI. Since executive functioning underlies many daily and social skills, such as impulse control, judgment, and emotional regulation, routine testing might not detect the degree of impairment evident in these areas. For example, deficits in executive functioning may lead to poor frustration tolerance or poor impulse control. During testing, patients may refuse to do tests, storm out of the testing session, or throw their pencils in frustration. Often these patients do not filter their own thoughts well and are inappropriate interpersonally. They either share too much information about their lives, or they can even ask out the neuropsychologist in an inappropriate manner. Neuropsychologists have found that using verbal fluency tests as a measure of executive function are reliable. These tests require TBI patients to organize verbal retrieval and recall and inhibit wrong responses. Emotional and behavioral complications are common after TBI and often lead to depressed and anxious mood, impulsivity, agitation, and amotivation. Mood disturbances are considered the most common psychiatric complication of TBI and are often the most difficult adjustment for those who care for the TBI patient. Approximately 10 to 60% of patients are depressed and report feelings of hopelessness, worthlessness, and anhedonia. Also, they display somatic symptoms such as sleep disturbances, reduced initiation, fatigue, and changes in appetite. TBI patients have reduced participation in leisure activities and have difficulty engaging in new hobbies. Mood disturbances can cause significant emotional distress in patients with TBI, contributing to the disruption of social relationships. This is the end of our lecture for today. Today's lecture covered the epidemiology of TBI, different causes of TBI, mechanisms of open and closed head injuries, recovery, including the Glasgow Coma Scale and post-traumatic amnesia, and the neuropsychological and emotional sequelae of TBI. If you are interested in learning more about TBI, here are some links for you. These resources are not required reading for the class, but are optional for those that find TBI fascinating like myself. Thank you for watching this lecture.